gonna start the workshop 5, and this session is mainly the focus on the high-risk PCI and the calcification. And the first part is high-risk PCI, and the second part is about the calcium management. Okay, I'm D.W. Park from Assam Medical Center and co-moderator Dr. Tsao from Taiwan, and we are invited wonderful panelists, Dr. Chui and Dr. Shozo Ishihara, Dr. Dong-Kie, and Dr. Yasusuke, and Dr. Simon Lo, Dr. Christina, Dr. Yong-Mo.
Okay, so the first lecture is from Dr. Duk-Woo Park from Assam Medical Center. His topic is the high-risk PCI in real practice, what we learned from tailored chip. Dr. Park, please.
Okay, thank you, Chairman. So my topic is about when you treat the chip, complex chip patients, you think about some different antiplatelet regimen. This is about the tailored chip trial. And tailored chip trial presented this year ESC hotline session number 7. At this time, 2 New England Journal of Medicine presented, and our clinical trial was published European Heart Journal simultaneously. And everybody know well contemporary antiplatelet therapy mainly based on the initial presentation, stable angina or acute coronary syndrome, or presence of absence, high bleeding risk. But in real practice, we have many chip PCI procedure, left main disease and the CTO intervention, multivessel disease, and the calcified lesion. And this case is a typical case. We are treated with a 5-drug eluting stent and the double crush technique, LAD diagonal, and the distal left main circle. Result is good, but we are concerned about the contemporary depth is quite enough for such complex high-risk chip population. That is the key rationale. So, and looking at the contemporary background published in New England Journal of Medicine 2021, and usually ischemic event is very high in the early phase, and the later time bleeding event much predominant. So our primary hypothesis, if you use in the early time much high potency antiplatelet therapy, early escalation, we can reduce ischemic event in the early period, and the late time we reduce the antiplatelet potency and adapt the de-escalation, we can reduce the bleeding event. That was a key rationale of our tailored chip trial. So we are adapted the temporal modulation and early phase and stronger inhibition. Later phase is weaker inhibition. So, and we are randomization is mainly targeting the chip population, high risk complex PCI population, and the randomization, one arm is clopidogrel plus aspirin, 12 months, and the tailored arm is early 6 months period we use the high potency, and we select low dose ticagrelor plus aspirin. In the later 6 months period, we are switched to the clopidogrel alone and the late potent antiplatelet therapy. So, and this is inclusion and exclusion criteria, and we have mainly targeting the high-risk chip population, left main disease, bifurcation lesion requiring 2 stents, CTO, severe calcified region, diffuse long lesion, multivess, complex PCI, more than 3 stents, 3 region, total stent length more than 60. And also we included medical treated diabetic and low ejection fraction. STEMI, non-STEMI patient was excluded. This patient, the potent P2I12 mandatory for 1 year. So as I mentioned, and we the standard arm is dual antiplatelet therapy, aspirin plus clopidogrel 1 year, tailored group, early 6 months, ticagrelor 60 milligram plus aspirin, ticagrelor 60 milligram potency much stronger than clopidogrel, and the late phase clopidogrel monotherapy alone. So primary endpoint was a net adverse event, ischemic event, all-cause death, MI, stroke, stent thrombosis, urgent revascularization, also plus clinical relevant bleeding, BAC2, 3 or 5, and also we evaluated diverse ischemic and bleeding outcome. And 2,000 patients was enrolled in this population. 24 sites in South Korea joined in tailored CHIP trial. And overall 2,700 evaluated. Finally 2018 was included in this trial, 1,000 in each group. And looking at the baseline characteristics, age is relatively young, 64, and the diabetic is very high, and almost 40%, and the stable angina is approximately 80%, 20% unstable angina. This is a high-risk criteria, left main more than 20, and the complex bifurcation lesion requiring 2 stents, 20%, and diffuse long lesion, 84%, multivascular disease, 95%, complex PCI, 48%, most of the patients having complex high-risk indication. So a number of region 2.4, 2.4, and the total length is 65 and 68 is very long. And because this trial was done in South Korea, IVUS imaging-guided PCI was done 71% in both groups. And this is a depth status of randomized group, and the standard group is aspirin and clopidogrel was maintained well. At the tailored group, at the 6 months point, ticagrelor plus aspirin is nearly totally switched to the clopidogrel monotherapy, and the primary net adverse event endpoint, and 1 year standard depth therapy 8.8%, and tailored antiplatelet therapy 10.5%. This is a hazard ratio 1.15, statistically not significant. So we failed showing the superiority of the tailored antiplatelet therapy. Looking at the major ischemic event, the hard clinical endpoint, death, MI, stroke, they are numerically lower with the tailored antiplatelet therapy. It's very early period within 1 week, and they are showing some lower event, but statistically not significant. And the bleeding event is much higher with the tailored antiplatelet therapy in the early period using the ticagrelor low dose 60 milligram BID compared to the dual antiplatelet therapy. But it's a major bleeding BAC3 or 5, no difference at all. Main difference was driven by BAC2 definition. And the landmark analysis in 6 months, and the primary net adverse event in the crossover within 6 months. Major ischemic event in early period better with the tailored antiplatelet therapy group, but statistically not significant. And the clinical relevant bleeding much higher in the early period. And this is a cardiovascular outcome. There was no difference, any ischemic outcome. And the bleeding event is much higher. Tailored antiplatelet therapy mainly driven by BAC2 definition, BAC3 or 5. Major bleeding is no difference between two groups. And this is a pre-specified subgroup analysis. Overall finding consistent in the various clinical factors, also consistent various anatomical factors. So, and our study limitation is open label design, and the overall event is lower than expected. Also, adapting net adverse event was limited in interpretation is outcome. And the summary of tailored CHIP trial, our trial failed to show superiority of a temporal modulation of tailored antiplatelet therapy, and the major ischemic event and any ischemic event no difference. Clinical relevant bleeding was much higher. This is the final key message, what we learned from the tailored CHIP trial. Our trial suggested tailored therapy undergoing CHIP population, CHIP procedure does not provide the net clinical benefit. This is absolutely challenging. More is a better concept, even in the high-risk CHIP population. However, we believe such a finding provided an important foundation for designing future clinical trial. Contemporary evidence mainly focus on the duration of the death or high bleeding risk population. Still, we have a very limited optimal tailored antithrombotic antiplatelet strategy targeting CHIP population. We require further RCT in the near future. Thank you for your attention.
Thank you, Dr. Park. And we have a discussion after 4 presentations. So I would like to introduce the next speaker, Dr. Kwang Yong Lee. He is from Catholic University of Korea, Seoul, and St. Mary's Hospital. His topic is post-TAVR PCI challenges and technical considerations. Dr. Lee, please.
Okay, thank you, Chairman. It's an honor for me to have a speech here today. I would like to share some of my cases and more focus on the technical considerations. First, we must remember that coronary artery disease is remarkably common in TAVI candidates, up to 75%. And data from the K-TAVI registry show that TAVI patients with CAD have higher mortality. And unlike surgical valves, TAVI frames, especially those with tall struts, pose a physical barrier for coronary reaccess. As the high-risk population grows and valve-in-valve procedure increase, and coronary access has become a major clinical issue. The reaccess study demonstrated a 7.7% rate of failed coronary angiography post-TAVI. Supraannular valves show more impaired coronary access than intraannular design. Supraannular valve preserve access in only 33%. And for intraannular valve, access is typically from above the valve frame. For a supraannular valve, we often need to thread through the diamond-shaped struts, which can be challenging due to leaflet and stand geometry. Let's think about the intraannular valve first. For intraannular valve, commissural tab orientation, skirt height, and implant depth are crucial for access. These red dots would be the opening of coronary arteries. A narrow ST junction and the commissural tab facing the left main can severely complicate engagement. We've got to attempt to engage from cell adjacent to commissural post. And if it's difficult, we need a rail guide using hydrophilic wire, balloon support, or guide extension catheter. In my center, we use a 3D CT-based simulation model to evaluate commissural alignment, sealing skirt height, and implant depth, which helps predict accessibility. In this case, a guideliner was essential to facilitate balloon passage and provide additional support for stenting. Proximal RCA stent was successfully implanted, assisted with extension catheter. And for left main PCI after TAVI, finding the correct coaxial view is critical for left main ostium detection. During left main stenting, the stent should extend slightly beyond the ostium because recoil from leaflet calcium and TAVI frame is common. Both immediate post-dilation and an additional NC balloon are usually required. The final IVC imaging demonstrated that even beyond the left main ostium, the TAVI strut and native aortic valve leaflet calcification may still impede coronary blood flow. Then next, let's think about supraannular valve. We need to think about the geometry of struts and leaflet, including commissural tab position. For supraannular valves, I generally start with a shorter catheter because the valve waist effectively narrows, so the functional aortic diameter could be narrow. In supraannular valve, advance the JT wire through the lowest diamond above the skirt, then engage the coronary ostium through the diamond cell directly facing it. And if the coronary ostium faces the commissural post of evolute valve, need to find the closest diamond like this. If engaging through the diamond in front of the ostium fails, try the valve to aorta free space approach when the VTA allows it. When valve to aorta space, like here, is wide, we can access directly above the valve. We can check it before the procedure through CT imaging. Also, our 3D simulation helps visualize whether coronary access is best obtained via the diamond pattern or through the VTA window, and also checking commissural tab position as well. After engagement, when you perform wiring with the workhorse wire, it will usually kick catheter out due to the wire friction. So using the hydrophilic wire reduces friction and helps prevent catheter kick out. And you need to swap to supportive wire once wired. And if a balloon cannot pass, a stronger backup support is mandatory. We can think about using guide extension catheter. In this case, after guide liner to secure additional length, the backup support improved as well. Stronger backup support also include guide extension catheter and anchor balloon technique and wire air mailing. The wire air mailing means sending the wire far distally to create a rail so the catheter can easily follow, and then anchor balloon and guide extension catheter advance are needed. After, in this case, we successfully finished PCI supported by guide extension catheter. In severely calcified lesions, if balloon dilation is insufficient and stent passage fails due to the poor backup support, then rotational atherectomy should be actively considered, especially in the post-TAVR setting. And after the procedure, careful catheter disengagement is needed because catheter can catch valve strut and kink, and advance guide wire into the catheter before removing the valve diamond to decrease kinking would be helpful. I believe valve-in-valve case will become an increasingly important issue in the near future. When considering the 4 possible combinations of TAVR valve, balloon expandable and balloon expandable offer the easiest coronary reaccess. However, they are hemodynamically not favorable because of a smaller EOA and high transvalvular gradient. So ladies and gentlemen, here is my summary today. Coronary reaccess after TAVR may be challenging in a significant portion of patients, especially for supraannular valve. Factors impacting coronary reaccess are listed beside. I think we need more focus on the VTA and strut and commissural tap positions. And here are my tips in technical aspects. Start with the shoulder catheter. And think about the access route. 3D simulation might help. And advance guide wire to enter valve diamond first, and then follow with your catheter. And hydrophilic wire first, and then exchange if needed. And consider stronger backup catheter and wire air mailing technique, anchor balloon, and guide extension catheter would make your procedure more simple and stable. Thank you for your attention.
Thank you, Dr. Lee. So the next speaker is Dr. Anthony Yu Tong Wong. He's from Hong Kong Sanatorium and Hospital. His topic is post-CABG PCI, when, where, and how. So, Dr. Wong, please.
Thank you, Chairman, for your kind introduction. So I'm Anthony from Hong Kong. So I have nothing to disclose. So I'm given the topic of when to perform PCI after CABG, the timing and patient selection. So what are the common indications for PCI actually for post-CABG patient? I think overall they are not really very different from doing PCI for native vessels. Basically, for acute coronary syndrome, you have no choice but to go in. And another indication would be significant ischemia refractory to medical treatment. But the consideration point would be all cases are cheap cases. Most are complex because of the underlying native anatomy, which would be very bad, and also the underlying graft anatomy, which usually would be also very hostile to PCI. And if we consider redo CABG, most surgeons would actually refrain from redoing CABG because of the advancing age, comorbidities, lack of viable grafts, that kind of reasons. So basically, the overall indication, although is similar for doing the first PCI for native vessels, the overall threshold for doing such an intervention would actually be higher. So we can separately discuss the timing of these interventions. Some patients present really early, within days after CABG, mainly because of very unstable hemodynamics or refractory chest pain, shock, that kind of things. And some people present late, like later than 1 month after CABG, which could be due to progression of native disease or some complication from the anatomy. And if we look at the venous graft failure and the arterial graft failure, the causes of the failure actually are quite different. If they present early enough for vein grafts, it's usually due to thrombosis or some technical issue like overstretching of the graft kinking, that kind of things. For arterial graft, vasospasm sometimes occur, but seldomly it would be due to thrombosis. Actually, mainly is about surgical factors. For patients presenting intermediately, like within 30 days to 2 years after CABG, for vein graft, still thrombosis is a major factor. Sometimes it's due to some venous arterial size mismatch. For arterial graft, many a time it will be focal hyperplasia at the site of anastomosis. For those that present late, for vein grafts, it's usually due to accelerated atherosclerosis. And actually, the patency rate of vein grafts is not that good. It's around 50% in 10 years. For arterial graft, it's much better, so it's very long-lasting. The failure rate is around 10% in 10 years. And if it really degenerates, it's mainly due to fibrointimal hyperplasia. So where should we target if we are going to do PCI for those patients? Before considering PCI, should we also consider CABG? Actually, if within post-operative period, like the patient present very unstable hemodynamic shock, then if such a strong indication, we would usually go in and do a coronary angiogram and see whether PCI would be feasible, because it is still preferred than immediately do CABG. For late graft failure, basically PCI should be the choice, unless you have available liver graft that is not used previously. So the problem with redo CABG mainly lies on the surgical problems. Like when you enter the sternum, when you open it, there would be vessel injury on sternal reentry, and also you may have used up like 3 grafts already, including a liver graft, 2 vein grafts, and there are lack of graft conduits lacking behind. And there's also some problem with arterial cannulation, cross clamping, because of dense adhesions around the mediastinum. And so overall, it should only be considered if the liver graft still is available for use. So for graft PCI, the potential complication mainly comes from a lot of thrombus inside the grafts that lead to no reflow, slow flow, and distal infarct once you open up the arteries. So there are actually many studies done comparing graft versus native vessel PCI in post-CABG patients. Basically, in a large meta-analysis, it is shown that all the MACE, the all-cause death, myocardial infarction, target vessel revascularization, all are better when you do PCI to native vessel, although it's a very complex PCI, rather than tackling the graft. The graft here mainly means venous graft, because this is the most commonly encountered problem after PCI. After CABG is still venous graft failure. When you do PCI to the venous graft, around 10% will give you no reflow and distal embolization, and the restenosis rate is actually quite high, around 25% in a few years. And for PCI to graft CTO actually is overall not recommended, because the patency rate is even less. And but sometimes, as a previous section has discussed, for CTO interventions to the native graft, to the native vessels, sometimes the venous graft can be used as a conduit. So what are the problems with arterial graft PCI? Well, actually, there are limited data available because arterial grafts usually last much longer. The main problem that we encounter would be when you deliver your guide wire there. Sometimes it would cause kink, it would cause a Cordon effect, giving rise to pseudo lesion. And sometimes when you touch the vessel, vasospasm can occur. Usually, the distal anastomotic lesion due to focal intimal hyperplasia can be dealt with simple ballooning. And how about the native PCI? For PCI to the native vessels, many are very bad vessels that need CTO intervention. You have to be familiar with both antegrade, retrograde approaches, use of atherectomy devices, rotablation, etc. But overall, the results should still be better than doing PCI to the grafts. So what are the potential way to improve those outcomes if you have to do PCI to the graft? Usually we actually kind of recommend routine use of distal embolic protection device if it's possible. And sometimes we do direct stenting so as to avoid slow flow from distal from embolization. And we undersize the balloon a little bit using imaging guidance. And be prepared to all the intracoronary vasodilator that you may need to tackle the slow flow phenomenon. For the use of choices of stent, actually bare metal stent, drug-eluting stent, the use of them in graft PCI is controversial, and I think both should be okay. But in many parts of the world, like Hong Kong, we only have DES left, so we will use DES. For native vessel PCI, the main problem is would be a very complex PCI, many CTOs, and so you have mastered all the techniques to do CTOs. So these are the potential problems that could arise from doing PCI, and these are the considerations which I will skip here. I just want to illustrate by showing you one not very complex case. A patient with CABG done a few years before RCA total block. SVG graft to PDA was actually patent. For the left side, the native one, you see the distal left main critical lesion and mid-circumflex CTO. And actually, the one that shown here is the diagonal instead of the LAD. So the LAD, mid-LAD was CTO also. The thallium scan come back to show anterolateral ischemia. So we want to tackle either the circumflex CTO or the distal left main lesion supplying the huge diagonal. You can also see that the SVG graft to the circumflex is actually blocked. And the limit graft to the LAD was actually patent. So we proceed, we choose the simplest one. We choose to tackle the distal left main lesion using imaging guidance, shortwave balloon, and then we open up the distal left main, supplying the huge diagonal. And the LAD is actually supplied by the Lima, so no problem with that. So for the circumflex CTO, we just leave it. I think overall for post-CABG PCI, the indications are similar to doing the primary vascularization. But in the range of the order, we favor native vessel PCI more than the graft vessel PCI rather than redo CABG. And we routine use imaging guidance. And you have to know your limitation. If you really think it's too difficult, please consult other colleagues. And don't forget about medical treatment. And actually, most of the time, medical treatment would be enough. Thank you.
Thank you, Dr. Wong, for the excellent talk. So the next speaker is Dr. Eun-Seok Shin, and she's from Aosan University Hospital, Korea. And her talk is all the DCBs, current status, and the future impact in complex PCI. So Dr. Shin, please.
Thank you for kind introduction. So drug-eluting stent has advanced and is highly effective. However, cardiovascular event rate remained higher than in native lesions, reported to be approximately 4 times higher. Furthermore, bleeding events after PCI are not uncommon and increase mortality. Drug-coated balloon, especially paclitaxel coated balloon, was associated with a low risk of major adverse cardiovascular event compared with the drug-eluting stent, and no significant difference in 3-year target lesion failure were observed. Last year, the ESH guideline recommended the drug-eluting stent, not DCB, for in-stent restenosis. However, we actually do not want to implant DES in multiple layers. To enhance DCB efficacy in DES IS lesions, neointimal modification with a scoring balloon specialty balloon has been shown to improve the anti-restenotic effect of DCB treatment. For successful DCB treatment after balloon angioplasty, performing the best possible lesion preparation with DCB in mind, the region is reassessed to decide the final device treatment. And if the result is favorable, we proceed with DCB treatment. However, if not, we implant a stent. This stepwise approach, endorsed by international and Asia-Pacific consensus statement, is known as DCB-based PCI strategy. And DCB works through balloon angioplasty, dissection, and media stretch, enlarge the vessel, and the drug prevent restenosis to promote plaque stabilization when combined with optimal medical treatment. So, how are complex lesions treated with the DCB-based PCI? In multivessel disease, the DCB-based PCI reduced the DS used by 64% and resulted in better 2-year outcomes compared to DS-only approach. In diffuse long lesions, DCB-based PCI reduced the DS used by 82% and lowered 2-year target vessel revascularization and major bleeding risk and compared to the DS-only PCI strategy. How about CTO lesion? And DCB-based PCI reduced the use of DES by 66%, especially for small DES, less than 2.5 millimeter. The 2-year target vessel revascularization and major bleeding risk were lower than DES only PCI, and these findings were consistent across multiple analytic methods. Kaplan-Meier curves demonstrated better major adverse cardiovascular event and TVR with DCB-based PCI in CTO lesions. Bifurcation is also a representative region of complex PCI. Unlike metal stenting, DCB does not cause cardiac shift. Instead, after DCB treatment in the main vessel, an increase in the side branch OCR area is observed, and OCT imaging clearly showed that even the DCB was applied only to the main vessel, the side branch OCR area also increased. It is related with the positive modeling in main vessel. In particular, DCB is effective for Medina 001 bifurcation regions. In our recent propensity matched analysis of 2 registries, DCB-based PCI demonstrated better outcome than DS-only PCI in terms of target lesion failure and target lesion revascularization. In these patients, we treated with side branch ostium with DCB and show excellent result at follow-up. How about left main lesions? Left main shaft and bifurcation and even left main CTO can be treated with the DCB if the region is adequately prepared. In these patients, only 3 DCB were used, and excellent results were achieved at 6 months follow-up. We recently evaluated the efficacy of DCB-based PCI in left main true bifurcation regions and were able to avoid DS implantation in 74% of devices, and the 1-year clinical outcomes were quite comparable to those of DS-only PCI. Chui PCI is also increasing in daily practice. The CHIP score from British Cardiovascular Interventional Society is used to predict outcomes. The maximum score is 20, and the highest score indicates worse prognosis. Importantly, a score of 5 or more is linked to high 1-year event rate of 12%. So we analyzed the CHIP score using our DCB registry and compared it with the DS registry in more than 10,000 patients. The distribution of CHIP score was quite similar between the 2 groups. In DCB-based PCI, patients with CHIP score over 5 experienced more cardiovascular events. However, those of score less than 5 showed no significant difference. In the propensity matched population, DC-based PCI was associated with lower MACE. At 2 years, the event rate was 31%. Blue color is an DS, and red color is an DCB group and 31% in the DS only group with the CHIP score over 5. However, 20% in the DC-based PCI group. For cardiac deaths, there were a trend toward better outcome with DC-based PCI. In the DES group, target-based revascularization did not vary in CHIP score. However, the DC-based PCI TVR was higher when the CHIP score was over 5 score. Major bleeding is less frequent with DC-based PCI than DS and compared to DS PCI group. So why is DCB treatment beneficial in complex lesions? It simplifies the procedure. We don't need to worry about where to start in complex lesions like bifurcation, CTO, or diffuse lung lesions. And device sizing and lesion selection are quite easier, and DCB requires shorter duration of antiplatelet therapy and those high-risk bleeding. It avoids the stent-related event, especially long-term, and allow easier repeat revascularization if needed. So here are the take-home message, and optimal lesion preparation is quite essential for successful DCB treatment, and it plays a key role in safely simplifying complex PCI. And DC-based PCI strategy simplifies treatment for complex lesion and high-risk patients. And by reducing stent burden, and DCB may improve long-term outcomes by minimizing stent-related event. So future studies will further establish DCB as a first-line PCI strategy for all common coronary artery disease, and not only for complex regions. Thank you for your attention.
Okay, thank Dr. Singh for the excellent talk. I think we have a few minutes to discuss. Any question or comments from the moderator or panelist?
Maybe I have one comment and question for Anthony. So I mean, post-CABG patients are always the most challenging cases because usually this patient progress very rapidly after CABG. The original would be a triple vessel disease and even progress after the CABG. So although I know, I mean, from many studies, or my senior told me that always intervene the native before considering the vein graft. But the recent Porter trial in the Europe said the reverse. I mean, intervention of the vein graft may be better than the native. So some people may comment that the vein graft is a simple lesion and versus the complex lesion of the native. So would you comment on this as well? And the other thing is you said imaging for the vein graft intervention. So how would you use the IFUS to size your stent and also the NC balloon? So can you enlighten us on this?
Okay, thank you, Dr. Chui, for the excellent question. I think it's kind of a judgment call. If it's a really very simple graft lesion, short one, and maybe the lesion has been there for quite some time, I think actually intervening the graft would actually be one of my choice. And basically, I would usually use IFUS to assess the graft size, but to like downsize 1 or 2 size, and then direct stand it. Yeah. And I think it's not based on any evidence. It's just kind of some experience. Yeah.
I have a question for Dr. Park. For the TAVR trial, the population are all from Asia, East Asian populations. So we know there is East Asian paradox, means less thrombotic event and higher bleeding risk in East Asian populations. So will this phenomenon affect your result?
Yes, I think so. You know, absolutely, the Asian population much vulnerable to the bleeding event. So after seeing our tailored CHIP trial, if you adapt more shorter escalation period is 1 month or 2 weeks, is I think much better for in terms of a primary net adverse event. Absolutely, and the most of the trial, and there are absolutely some the Eastern Asian paradoxes. Asian population much vulnerable to the bleeding event rather than ischemic event.
Thank you.
Same question, just to extend that, Dr. Park. If you had used 90 milligrams of ticagrelor, would you have, just expectation only, could you have seen a different result in the primary endpoint?
Yeah, so and the main reason to select 60 milligram was based on our double-blind trial, Optima trial. We are comparing the double-blind clopidogrel, ticagrelor 60 milligram, ticagrelor 90 milligram. Was 60 milligram platelet inhibition potency is very similar to the 90 milligram, but I think we adapt 90 milligram is bleeding event much larger. Yeah.
But if you said the potency is similar, then how can 90 milligrams be worse than 60 milligrams in the bleeding events?
Yeah, it's absolutely 90 milligram is on the basis of Pegasus trial bleeding event much higher than 90 milligram than the 60 milligram.
Okay. The Hong?
Yes, I'd like to ask Dr. Shin for the DCB. The first question is the content of the DCB in the current status should be included leakage-free one study which was published in the Lancet. The whole content of it is just like the registry-based data is some biased the opinion. And second one is the slide in the OCT to show us that the positive enlargement in the 9 months, actually it is not the drug effect. That is made by the huge dissection. Such kind of appearance is usually seen in the bare metal stent era in the DCA, and after the DCA, huge dissection, and then it's a similar finding. It is not the DCB. And finally, what is the underlying mechanism of the DCB? Shows the compatible the clinical outcome or TS. What is the mechanism? I think is the bigger is better in the PCI procedure, and the DCB, even though the adequate region preparation, residual diameter stenosis study, but when we deploy the stent, residual stenosis is about 5% or 10%. Such kind of the diameter stenosis is a leakage-free study. One study clearly showed that the diameter stenosis in the DCB is 25 and the TS is 15%. What is the mechanism of the TS shows the favorable clinical outcome?
Thank you for your quite very important question and comment and the criteria of 30%, less than 30% residual diameter stenosis is from the previous and balloon angioplasty era. We have so many evidence of the 30%, less than 30% residual diameter stenosis is quite comparable clinical outcome with the metal stent. I mean just bare metal stent. And so the criteria is from the previous and quite very strong evidence. And number two is a DCB effect.
What I mean is using a DCB and the residual stenosis less than 5 or 10. That is the criteria, is the adequate region preparation like a stent.
Yes, right after DCB treatment and the angiograph result is worse compared to metal stent, DS implantation. And however, that is not related with the clinical outcome. I mean, and the target-based revascularization or target lesion revascularization is quite comparable between the DS and DCB treatment in de novo coronary artery disease. However, the clinical status when they developed an event, DS is related with the acute coronary syndrome feature. But after DCB treatment, the event is occurred and with the stable angina feature. That is quite different. I think there is some related with the different and clinical outcome between the DS and DCB. And the DCB effect is quite interesting. There is not with the simple balloon angioplasty, because that especially in the paclitaxel drug is rapidly and absorbed in the intima, and that is going through the media and adventitia. So, and in the animal study, we have some animal study, and so within the 2 weeks, paclitaxel is much accumulated in the adventitia. That is associated with prevent the coronary recoil, not only the prevent intima hyperplasia. There is many mechanisms of paclitaxel coated balloon treatment.
Can I ask one question for Dr. Shin?
Okay, last question. We have a limited time. Okay.
Sorry. So the DCB is worldwide spreading now, and also in your country, Korea, and also in our country, Japan. So IVAS and imaging usage is very high. So that if we finish the DCB, so imaging assessment is very important. It's my opinion. How do you think about that? Because some countries cannot use IVAS so much. Yeah, it's a problem.
Yes, and imaging-guided DCB treatment is very important in terms of then choosing the accurate preballoon sizing and DCB sizing. However, and in one trial is compare the angiography outcome between the imaging-guided and angiography-guided, but angiography result is quite good in the IVUS-guided DCB treatment group. However, in the outcome is quite different story. So the outcome, we need the outcome trial from the imaging-guided and angiography-guided.
So you mean it's better to use the imaging for DCB?
In our recent study, that is it's just submitted in ongoing and revision now, and the clinical outcome is quite comparable between the angiography and IVUS-guided DCB treatment.
Okay, thank you. And because of time limit, we're gonna move to the second part. And the second part is calcium management. And we would like to invite, the pioneer and the complex PCI, the master, and the Professor Antonio Colombo from Italy. And the title is How I Approach the Calcified Region.
Thank you very much. So I try to make it this topic relatively simple and straightforward. I have nothing to disclose. So there are many devices, but in my practice, the device that we use the most are non-compliant balloon, super high pressure balloon by the Swiss company, cutting balloon, IVL, and rotablation. We don't use much orbital atherectomy. These are the 4 devices that make, I would say, 90% of our use. My algorithm, when you see a calcified lesion on angiography, we do IVUS most of the time. If the IVUS does not cross, we go rotablator. We have a low threshold to do rotablator, and we don't waste time we use a 1.5 2.0 balloon. If the IVUS or OCT crossed and we see severe calcification, I don't want to bother you with the 108 to 120 degrees severe. We consider rotablation or IVL, depends on the type of the lesion, the type of vessel. We consider high pressure balloon or cutting balloon, and decision is made upon the availability, the cost, and the experience of the operator. If we see a calcified nodule, we go a little bit different. We consider orbital, IVL, of rotablator if favorable bias. We don't go with a super high pressure balloon with a calcified nodule because you may get vessel rupture on the other side. Then if everything goes fine, we always finish or almost close to the end with a high pressure non-compliant balloon. I call it the common denominator before doing the final procedure. Then after this, we repeat IVUS or OCT. If we are happy with the result, we go stent or DCB, depends on the clinical setting and the type of result. If the result is not acceptable, we try again with OPN, repeat cutting at high pressure. We repeat IVUS to make sure that you get a good result. If the result is good, you do stent or DCB. If the result is no good, we don't do stenting, or you do nothing, or you do a DCB, because to implant a stent in a suboptimally prepared lesion is a mistake. Sometimes you don't need all this business I just showed you. If you see this type of lesions, you know that you're not going to spend time with a high-pressure balloon. You need a rotational atherectomy. So sometimes the decision-making is quite simple and straightforward. In this calcific lesion, you need a rotablator. So rotablator is a must if a small balloon does not cross or the IVUS does not cross, is appropriate if there is a big arc of calcium, etc. Sometimes we prefer IVL because we know that is safer, especially if you do not have a large experience with rotational atherectomy, and if the vessel is big, it's definitely more effective. But in this case, we do the rotational atherectomy on both vessels, of course. Then we do intravascular lithotripsy because the vessel is small and you cannot achieve a good result only with rotational atherectomy. Then we do a high-pressure balloon, we repeat IVUS, we do additional dilatation, and then we go to stenting. So this is a very repetitive paradigm, and you don't really need the fantasy. Some question: if you see with imaging severe calcification, should you try high-pressure balloon and evaluate the result, predilate with cutting or use lithotripsy? I prefer to use IVL and then high-pressure balloon. It's a more modern approach. Can we assume that using lithotripsy upfront may cause more benign dissection? I think yes. May cause dissection, but they usually are less extensive. If the balloon is fully expanded, can we assume that the calcium is broken? And the answer is no, because eccentric lesion can mimic full balloon expansion and the calcium may still be intact despite the balloon is fully expanded. This is the long lesion. We did the shock wave. You see the result in some area is not acceptable, but there are some area broken. We do high pressure balloon. This is another lesion. Despite the shock wave, the result is not acceptable, but with OPN, the result becomes acceptable. So one single device is not always the answer. There will be a talk on calcified nodule. I don't want to spend much time, but just to tell you that be careful with a very high pressure balloon with a calcified nodule. If you don't have other devices, do not oversize the balloon. Do not go from media to media because you may break the vessel. Consider rotablation if you have a favorable wire bias, orbital atherectomy of IVL. If you do IVL, try to position the emitter near the nodule so there is more chance that the nodule may break. But do not oversize the balloon. Not in oversize, do not appropriately size the balloon, but downsize because you may cause rupture. So in these cases, we prefer to give the priority to IVL, and rotablation will work only if the wire bias is favorable, and orbital atherectomy may work. OPN is a very important device. Sometimes even after IVL, especially if you have in-stent restenosis, is the only way to achieve a good result. So do not forget that this device is important. And to finish, with IVL is not anymore essential, but in the old time, for severe in-stent restenosis with calcium, the only way was to use excimer laser with a contrast injection. We published a series. Nowadays, with IVL, this needed is not anymore present. So the take-home messages are rotational atherectomy is a dominant procedure. You can treat almost every calcium. IVL should be used liberally. Cost may be an issue. High-pressure balloon, sometimes cutting, are always in the armamentarium. And without imaging, no appropriate treatment of calcified lesion takes place. Thank you for your attention.
Thank you, Antonio. And after hearing the full lecture, we will have a Q&A time. And the next title is Michael Lee from US and choosing the right tool for calcium management. And Michael?
Great, thank you. Dr. Park, I just want to congratulate you for a decade of excellence in this conference. It's been great. I just wanted to tell a quick story about Dr. Colombo. So when I first started at UCLA, my colleague was John Tobis, and he passed away this past year. And just to give you an idea of the influence he's had on John Tobis and myself, when I first started, I started doing rotational atherectomy. Every time I made a pass, patient's blood pressure would go down. And basically, John Tobis told me that Dr. Colombo taught him, rather than using the rotoflush, he would put 10,000 units of heparin in a liter bag of saline, and basically I would no longer have hypotension. So how you practice, that's translated to me. So I'd like to thank you for your influence for us. Thank you very much. You know, the title of this conference is called Make It Simple. And I'm going to give you kind of a timeline of how we treat calcium. So rotational atherectomy, it's not quite simple for everybody. You realize a lot of people don't use this technology. This is an 86-year-old female. She was very sick. This is prior to any other devices for plaque modification. And this is truly a no-option patient. She was not considered a candidate for CABG. She had bronchiectasis, so the possibility of this patient coming off the vent was very low. And you can see she has subtotal osteo left circumflex, severe left main disease, LAD disease. So you don't really want to start off big and heavy. You don't want to start off with a 1.5 or 175, but you're going to eventually have to get to a higher size burr to get complete and full plaque modification. So what we did was start very conservatively 1.25, then we switch out, go to a 1.5 and 1.75. But when you make multiple passes, eventually the rotofloppy wire will get very sticky, grimy, and you get lint. And sometimes when you try to exchange, it's hard to pull out. So one of the tricks that I've learned is that when I do biopsies, we use what's called a Telfa pad. Telfa pads don't have lint, so we use that commonly to wipe down the wire. So this takes time, and when patients develop hemodynamic instability, when you need to address the lesion quickly, this takes up time. So once you do atherectomy, at this point it becomes a relatively straightforward procedure. You do the crush technique, and we place a stent in the ostium with an eleocranial view. We do a final kiss, and this is your final angiographic result. But again, this takes time. Subsequently, in 2012, orbital atherectomy was introduced, and this was really my go-to device. This is really a device that really changed how I practice. You know, rotational atherectomy has been really the gold standard for the past 40 years. It was actually developed by an electrical engineer, David Oth, at the University of Washington. But 2012 was really kind of a seminal moment. And what the benefit of this device is that it almost is like a 1.5 burr and a 1.75 burr. So when you go low speed, it's a 1.5 burr. And when you go high speed, you don't have to swap out. You go to a 1.75 burr. And it's quite simple. And you see here, look at the rotational atherectomy. When you spin, you really have only contact with a greater curvature. But with orbital atherectomy, you have contact 360 degrees. So you're getting contact with the greater and lesser curvature. This is one case where I applied atherectomy. This is a 68-year-old male who's being evaluated for a lung transplant. Clearly not a great option for CABG. It's going to be difficult, again, to come off the vent. So very straightforward. Once you get the wire down, and the wire is much more easier to use compared to rotofloppy wire, much more supportive, you make a couple of passes, And you go very slowly, deliberately, unlike with rotational atherectomy where you could go back and forth like a windshield wiper. This requires going very deliberately, very cautiously. And this also develops a pitch. So you realize when the pitch, the high cadence is gone, you realize you've done enough atherectomy. So again, this is your final angiographic result. There's a questionable lesion in the ostium of the circumflex. You do FFR, and if it's not physiologically significant, you leave it alone. But last year at TCT, Ajay Kurtane presented the results of the CLIPS trial, and surprisingly, it did not show a clinical benefit. There was no improved clinical outcomes compared to conventional balloon angioplasty. Now, back in 2021, another pivotal event. That was when IVL was introduced. And you could see since then, there's been a steady rise in the use of IVL. And you can see over the course of even today, there will be a 35% estimated global IVL penetration, and the compound annual growth rate will be almost 50% by 2030. This is one of the earlier cases that I performed. This is a 62-year-old male, had severe cardiomyopathy, severe PAD, actually had such severe PAD where we could not use Impella. Did not have much viability in the distal LAD, so we're just going to address the prox LAD. Now, this is a regular 3.0 balloon that would not fully profile, so at this point we decided to go not with a coronary IVL. One of the limitations of coronary IVL, it's only a 12-millimeter balloon. We used a 40-millimeter peripheral balloon, and just at 4 atmospheres, just see how well it profiles. And it's very slick, very elegant. After we get the balloon to dilate, we stent the ostium in the left main, we do a kissing balloon, and here's your final angiographic result. Now, one of the limitations of the current generation of IVL is the crossing profile is not great. Number two, like they talked about 12-millimeter balloons. So if you have a long lesion, you have to do multiple inflations. This is one company I'm working with. This is called FastWave, and this is an example in the earlier cases. You can see a mid-LAD lesion. Now, this is unique. Number one, it uses a one-fiber design, so it improves the crossing profile. But number two, unlike IVL with Shockwave, which has 2 emitters, this has 1 emitter. And you can see at the throw, it goes back and forth. So let's see how it's used in clinical practice. So you see how the emitter goes, and where it's not profiling, it'll sit right there, and you could deliver the shocks. So unlike where you have just 2 emitters that just emit without any targeted inflations, you could actually direct where the emitter will be. This is another example where you could control the emitter to the desired location. This is interesting. Last month, there are 2 alternatives. So IVL, Shockwave, $5,000. That's almost as much as a business class ticket from JFK to Incheon and back. Very expensive. There's some other options. At TCT earlier or last month, what about the use of OPN? Well, in this trial, they had a comparison with OPN compared to IVL. OPN is much less expensive compared to IVL. And this was not a clinical endpoint. This is a stent expansion. And you can see there is non-inferiority when you use OPN balloon compared to IVL. If you look at the secondary endpoints of 30-day clinical endpoints, no difference. Again, very short-term outcomes. And lastly, the shortcut trial. Now, you think about the cutting balloon. It's been around forever. It actually was developed at Cedars-Sinai, where I trained. One of the limitations with cutting balloon angioplasty is that the crossing profile is very poor. So in the press conference, Suzanne Barron said if the cutting balloon doesn't cross, then at that point you can use IVL, but then you just basically opened up a $1,000 balloon. So maybe that's not a great option. Personally, in my practice, I don't need much cutting balloon, if at all. And if you look at the primary endpoint of post-procedure MSA, no difference in terms of MSA. So in conclusion, IVL and atherectomy are reasonable treatment options for the treatment of severe coronary calcification. We really need more studies to identify the ideal treatment strategy, but less expensive options other than IVL include OPN and cutting balloon. Thank you so much for your attention.
Thank you. Thank you, Michael. And we're going to move to the third speaker, and Dr. Masaki Okuchu, and Imaging-Guided PCI for calcified region.
Thank you, Chairperson. Good afternoon, everybody. My presentation is about the Imaing-Guided PCI for the calcified lesion and happiness disclosure. The calcified lesion is very hard because there is no enough solution and no enough device, no enough modality. So the calcified lesion have so much have a problem still now. And then recently, these two calcium scoring system is are the major assessment modality to predict the atherectomy device use in PCI. However, there are some limitations of the intravascular imaging divided calcium scoring. The number one, the imaging catheter sometimes cannot pass the region. The number two, the imaging is evaluated during the procedure, not before the procedure. So, and number three, the calcium score predict the necessity of the atherectomy device, but do not predict the efficacy of this device, basically. And then the latest consensus document recommended that these four modalities to assess the calcification below the PCI. And CCTA was introduced to have the one advantage. This is the non-invasive imaging prior to the calcified laboratory. This is the only advantage in this literature. However, any other advantage is not described. It's maybe I have. I think the CCTA have a much more advantage for predicted for assess the calcified regions. Then, I would like to discuss this about these two issues: the necessity of the atherectomy and the efficacy of the atherectomy. These 2 points is quite different. The necessities may be evaluated by the quantitative analysis, and the efficacy will be there assessed the anatomical analysis. By using the CCTA, it's a very big challenge to answer these these 2 points. Then the first challenge, this is calcium thickness in the CCTA. The length and angle is not so difficult to measure by using the CCTA. However, thickness may be impossible to check by using the CCTA. However, I introduced the new algorithm to assess the calcium thickness by using this formula and with the peak CT density of the calcification. So by using this method, then we can obtain the CT calcium scoring. But now I'm checking this data, and so now going. Recently, we introduced this paper, and we checked the case which were treated by the Rotablation, and these 4 factors were associated to the use of the Rotablation. The calcium angle more than the 290, and calcium location in the bifurcation region, and calcium mass-like image, and calcium length. These 4 factors were the associated to the Rotablation use, and more than the 2 point, there is a good predictive number of the use of the Rotablation. So before the PCI for the calcified region, these and findings should be checked by using the CCTA. And the second challenge is the guide wire bias. Usually we check the guide wire bias by using the intravascular imaging. This is very important to assess the efficacy of the atherectomy. However, can CCTA predict this guide wire bias. It is very challenging. And then, as you know, very near distance for guide wire between the guide wire and the vessel wall is a good predictor for the good atherectomy with the rotabrator or the OS. Then, by using the CCTA, I constructed like this 3D image of the coronary artery and with the calcification by using the with a secret algorithm, and then draw the guide wire bias line inside the coronary artery lumen, and then we can assess the guide wire bias before the PCI. It's very important and useful. And then I create the 3 pattern according to the guiding catheter position, the down course and the horizontal, the upper course. And then this is a case. This is a bifurcation core and the proximal LAD and the mid LAD. And then checking this point inside the coronary artery, and this is the image. And these 3 points have a good guide wire bias, and OCT image shows the same, the good guide wire bias. After rotabrator, we can see the good atherectomy effect. And this is a RCA case. RCA case is also same. The CCTA image showed these 2 points have a good guide bias, and this is maybe also same as the OCT image. So the necessity should be evaluated by the calcium score, and the efficacy will be assessed by using the guide wire bias. Then in CCTA, these 2 assessment can be done. So if the lesion have 2 factors, high calcium score and the good guide wire bias, then go atherectomy. This is the appropriate step to the calcified lesion. And then the CCTA has a potential to be the gold standard to evaluate the calcification. And so to do the passion may be important for this work. Thank you very much.
Thank you. We have the 13. The next speaker is a new approach for the DCA for calcified nodule, Dr. Takamura Chuda.
Yes, thank you, Chairman. I'm talking about the DCA for the calcified nodule. So I'm not intend to denying the rotabrator or OS for calcified lesion. But nodule calcification is very different in terms of the pathological aspect. So and also in the long term, clinical outcome is very, very good, very, very bad in the calcified nodule, both in the eruptive calcified nodule and also the non-eruptive calcified nodule. So the right one is a very representative case of the acute stent failure after the stent implantation. So the neo calcified nodule was grown up inside the stent. So once the ISR occur, the TLR rate is quite high in the calcified nodule. So by using the DCB or DS, very, very high ISR. So the DCA is a very unique device. So one side is a cutter, and the other side is a balloon. So when the inflate balloon more, the plaque will debulk more by the cutter, like this. So this is a representative case of the left main ostial lesion by using the DCA. So by using the perpendicular angle, so I performed the several cut. So by using the DCA, so in the spider view, the left one is a cutter, right one is a balloon. Okay. So finally, this plaque was well ablate well developed by using the DCA, so finalized with the DCB, non-stent strategy. So this is 40 years old maybe the CCS, so there's some aneurysm inside the LED. Okay, so inappropriate anatomy of the stent implantation because of the malposition. So baseline IVS showed that clearly demonstrated the calcified nodule at 12 o'clock. So that's why I performed the DCA for the calcified nodule. So finally, the several attempts. So finally, the DCA could obtain the very large acute gain without any dissection or the hematoma. So compared to the baseline angiography. So finally, the final is the stentless PCI also. So this is a ACS case with a LED proximal lesion. The baseline IVAS clearly demonstrates some unstable plaque and also some calcified nodule was both combined. So first of all, I performed the long inflation technique by using the perfusion balloon. Okay, so at this time, we finalized the balloon angioplasty only at this time, the primary PCI. So I plan to the staged PCI for the left main LED ostial lesion. So baseline IVAS clearly demonstrates the unstable plaque was already disappeared, right? But severe calcification and also the calcified nodule still remained. So that's why first of all I performed the Rotablation 2.0 by the 140,000. Okay. So I will clearly demonstrate some calcification was well developed by the 2.0 Rotablation. So after that, I bring the DCA caster to the LED proximal region and abrade the residual plaque, including the calcification. So compared to the baseline IVAS, so finally IVAS demonstrate that very large acute gain was obtained only by the DC caster. So finally with the DCB, so stentless strategy. So this is a more complex case. So RCA ostial lesion. So very severe tight stenosis. So the RCA ostial lesion is very Achilles for the PCI as the same in the circumflex ostial. So I was demonstrated some thrombus, unstable plaque with the calcified nodule was observed at the RCA ostial lesion, like this one. So first of all, I performed the Rotablation 1.5 by the 180,000. So to abrade the calcification itself, the Rotablation is very effective. So, but it depends on only the guide wire bias. So very difficult to abrade not appropriate guide wires. So the 1.75 was performed, and balloon angioplasty and the DCB was deployed to the RC ostial. As you know, the RC ostial is suboptimal, so it's not a good case, right? So, but I was clearly demonstrated that some lumen was obtained by using the Rotablation, but very severe calcified nodule was remaining at the RC ostial region. So that's why I performed the staged PCI for this region. So IVAS clearly demonstrated that some plaque, some soft plaque was already decreased, disappeared. So that the calcified nodule only remained inside the RC lesion. So first of all, I performed the Rotablation 2.0 by the 140,000. So actually very, very tough lesion. So that's why the maybe the 20,000 speed down was occurred in this case. But finally, the Rotablation was passed, and it looks good. But in IVAS demonstrated the residual calcified nodule was very, very huge. So that's why I bring the DC caster also in this case to ablate the calcified nodule. Okay. So finally, we can get a very, very good angiography after DCA. So finally with the DCB also. This is a final angiography for this case. So looking back to the IVAS examination, so compared to the baseline IVAS, the Rotablation could obtain the very large acute gain, but after the DCA, compared to the post-Rotablation 2.0, so larger lumen was obtained by using only the DCA. So this is a baseline and final angiography. So compared to the baseline angiography, so final IVAS clearly demonstrates a very large acute gain without any dissection and also hematoma. So actually, there's many tips for the DCA itself. It's my style and also very difficult to say here. And to say is very easy, but to do is different thing. So, but anyway, the calcified nodule is very big enemy with a high rate of stenosis in PCI. So, however, the DCA could be one option for the calcified nodule. Thank you.
Thank you. Thank you. We have a 5-minute discussion time. Any question to the speaker? Any? Okay.
Question.
Okay.
Sorry. Can I ask Dr. Takasu regarding the last 2-3 cases? I noticed that you debulk all the cases with some devices, but you never implanted a stent. You just put a DCB there. Personally, I'll be a little bit frightened with some of the cases because debulking means you remove part of the endothelium, which is important for the healing process. If you remove some of the endothelium, would that predispose the patient to a higher risk of some thrombosis or something else?
So as you know, that the nodule is growing up within the few months later. So that's why the acute gain by the atherectomy itself is very important. So the DCB is one option, and also the DS is one option. But in my current strategy is to obtain the more larger acute gain only by the atherectomy device. Okay.
Okay, Professor.
I also asked Dr. Tsuda, your case is great. That is the definition of the adequate region preparation. And geographically, about less than the 10%. That time, maybe the initial situation to comparison the stent. So without the DCA, I think it's a very difficult. So when I look at his cases, it's the best example for the adequate region preparation for the DCB.
So maybe the Dr. Ishihara sensei is also my colleague, so and maybe my supporter. So and the DC is now current system is semi-French, and also the newer device will be more slender, launched in only now is only available in Japan, but in near future the Nipro company will be bring every company. Every country. So,
Antonio?
But, you know, we used to do DCA many years ago, and what you showed, Dr. Suda, is very correct. You get a great result, and I think if you get a good lumen like you showed, you don't need a stent. Calcium is already a natural stent if you don't have recoil and you have demonstrated. The problem is that Nipro doesn't want to bring DCA outside Japan. We have been talking for them for the past 5 years, but they say maybe, but never happened.
I will strongly request again.
Kind of question for Dr. Tsuda also. You in your slide you said the calcified nodule needs more aggressive debulking. So the RCA osteo lesion, there's a very big calcified nodule. You use rotablator and DCA. How about you use rotablator plus orbital atherectomy from backward sending? Are they different from your strategy?
Yes, thank you. The DCA have some problem during the delivering. So the device itself is very not so crossable. So that's why and also the best size need also the larger best size, more than 4 or something. So that's why the indication was completely different from the rotablator or orbital. Actually, the orbital and also rotablator is very effective for the calcified nodule. So in the case with a very appropriate guide wire bias, so in that case, the very effective. So that's why I also use the rotablator. But by using the DCA, so larger gain could be obtained much than the rotablator or IVL or the OS. So that's why it depends on every case.
Okay, I have a short question, Antonio, and I think your lecture is if you apply to the IVL for some severe calcium, and you can IVL induced more benign the calcium cracking, and each step you evaluate the imaging. So, but IVL is available in South Korea, but the price is very costly. It's more than $5,000. So, in your experience, and when do you decide to apply IVL based on IVL's finding in the Colombo? And
In the private hospital, we have no concern because the money is not an issue, but in the public hospital, we try first with high pressure cutting balloon, and many times with high pressure cutting balloon we can improve, and OPN is also a good alternative. But if the lesion has been prepared with rotablation, you can live without IVL. If you know how to do rotablation, if you use rotablation 175 and you have OPN, I mean, you live without IVL. But, you know, if you have IVL and you have the money, nothing wrong.
Okay, it's depending on money. Okay, I think it's time already done. We're gonna finish this session. We move to the next session. Thank you.